Use your eyes, know yourself, realize, understand and empathize. We could learn to fill the world with love.
Good evening, everyone. I am Cosgrove, CEO of Humanists Australia. I'm here with our creative director, Brian. Before we begin, I'd like to acknowledge that I'm speaking to you today on Ngunnawal and Ngambri land and acknowledge that sovereignty was never ceded. I pay my respects to their elders, past and present, and recognise their continuing connection to culture and country. I acknowledge and pay my respects to all Aboriginal and Torres Strait Islander people here today. I promise to listen deeply to your voices with an open heart and to stand up for justice, treaty and truth. We have two very special guests with us here tonight, Sam Delaney and Iain McKinnon, for our conversation tonight on voluntary assisted dying. Iain is a former palliative care nurse and has his own business as an end-of-life coach, funeral arranger, planner and celebrant, and is an accredited humanist celebrant. Iain is currently the Victorian and Tasmanian Chapters Coordinator for Exit International, an organisation that believes that control over one's life and death is a fundamental human right. Sam is President of Dying with Dignity ACT, a non-profit group of volunteers committed to law reform that has advocated for the ACT VAD laws that are about to come into effect next month. Welcome, Sam and Iain.
Thank you.
I'd like to start out asking you both, or maybe even all three of us, what is your personal experience with VAD and why are you so passionate about it?
Iain,
would you like to go first?
Thank you.
Yeah.
So I guess I've supported a number of my clients in my business who have accessed VAD, so I have had some first-hand experience of their journey accessing the program and being there at the end when they've used their drugs. So I've had that personal experience and found it to be, a wonderful, dignified way of someone ending their life. In all of the instances that I've been involved with, it's been a very peaceful and dignified death. And the important thing is that they have the choice to decide when to go and where to go. And I think that is very important. And I think that was born out of my earlier work as a palliative care nurse when I was particularly in the 80s and 90s when I was working in AIDS, HIV at the beginning of that epidemic and experiencing a lot of death in young people who hadn't otherwise expected to die. And so it raised a lot of things about choice and the importance that brings us, particularly when we're vulnerable. And so I've been a strong advocate of voluntary assisted dying, really, without actually knowing that was what it was called in my head. That was something that was important to me as a concept. And then when we started talking about it and it started being implemented across the world, I became very interested in it personally.
How about you, Sam?
Oh, look, as with many of us that advocate for voluntary assisted dying, I have a deeply personal experience, but I came to this relatively recently. I'll try to keep this short. In 2017, I stumbled on a podcast. It was the first podcast I've ever listened to that was by Go Gentle Australia on what voluntary assisted dying might look like. And it was called Better Off Dead. At that stage, my mum was in the late stages of early onset dementia. So the circumstances were already highly complex and would sympathise. She was already going in and out of nursing homes. She'd already been in palliative care, technically speaking, for many years. I listened to that podcast by Go Gentle Australia in 2017, and to say I was on a steep learning curve about voluntary assisted dying would be a major understatement, but it definitely resonated with me at that stage. It resonated very deeply to the extent I probably had to step away from it for a few years while Mum was in her last days, until 2022, the territory rights debate came up in ACT, and I hope your members are probably familiar with the territory rights debate in Northern Territory and ACT. And I stumbled into this. I happened to meet a local senator who was trying to get elected, and got chatting with him in 22 about getting elected to the federal parliament. And the next thing I knew, I was behind the scenes helping quite a bit behind the scenes with getting an ACT program implemented. Along the way, I probably should identify that along the way, I didn't think any of this that would actually help anyone that was in palliative care with dementia, but that is now an area that will need to be unpacked.
There are a lot of complexities there, aren't there?
Yeah, particularly in the circumstance of ACT. Yeah, so I've got a deeply personal background, not a legal one, but I try and keep up with all legalities and keep on top of things, as most of the advocates around Australia do. I should just mention, I think Victoria had their anniversary of 50 years of dealing with this issue. So I'm in quite a different demographic to some of the advocates, and I take my hat off to everyone that's been doing this for longer than I have.
I've got my own experience with this. I've been advocating for voluntary assisted dying since, for about 20 years now. My mother made the decision that she would end her life back in 2004. So voluntary assisted dying was not legal in the ACT at that time. My father and I sat with her as she died, and because it wasn't legal at that time, that meant we had to go through all of the legal repercussions of that, and it was a very traumatic experience for both of us. And so that is why I'm passionate about advocating for voluntary assisted dying and making sure that the people who really need it can have it.
Absolutely.
So you mentioned earlier, Sam, the Territory Rights Act. It was the Northern Territory that was the first Australian jurisdiction to legalise VAD back in 1995. And do you want to tell us a little bit about what happened after that?
Well, at that stage, I was quite young. I was in, I think, year 7 in high school. But the states had, the territories had made their decision, and then the federal politicians came in over the top and said the territories can't make decisions on that for themselves. I think on the matter of voluntary assisted dying, please fact check me. I think in the 2 decades after that, there was more than 20 attempts to overturn that decision. And what it took was, to his credit, in 2022, when David Pocock was trying to get elected, he said that in the first 100 days, I would happily look at this issue and, according to my constituents, try and get this overturned. Whether I disagree or agree with it or not, the territories have their own capacity to make a decision on this. And fortunately, politically speaking, that finally got through.
Yes, so the Northern Territory rights were overturned in 1996 by that bill, the federal government bill, and then it wasn't until 2022 that the territories again became eligible for voluntary assisted dying legislation. In the meantime, Victoria was the first Australian state to legislate for VAD and have that legislation stick. Would you like to talk a bit about Victoria's legislation,
Iain? So I guess, as other states and territories have followed, it took a lot of time to, as legislation does, and a lot of people who were very interested in trying to make this happen. Philip Nitschke, who was obviously heavily involved in the Northern Territory legislation, and was the doctor who actually was responsible for administering the drug to the 4 people who ended up dying before that legislation was overturned. No longer living in Australia at the time, but very active, along with many other people. Rodney Syme being one of them, who in association with Dying with Dignity here in Victoria. Fiona Patten, one of the senators at the time, was also a key person. I think, like a lot of this legislation, they looked at people like Andrew Denton, who's now with Go Gentle, who was a great advocate for it. There was many people. They looked at overseas in Oregon and other jurisdictions where there was already some legislation in place. And as is always the case, I think the proposal that came up was watered down significantly in order to get across the line. In the end, I think it only passed by 4 votes in Parliament, but nevertheless, there was a view, and there still is a view, I think, that Victoria's legislation is the most restrictive voluntary assisted dying legislation in the world. It had so many factors built into it at the time to protect people, not unreasonably. But I think that what people wanted to see in the early days, we're seeing some of that now in, say, the ACT proposal. But because
there's some advantage to coming last, you get to make the legislation that's a bit more progressive.
Correct. And so I think the initial tabling was quite progressive, but there was a lot of dissent, and of course people to vote to support it would only do so if certain things were removed and watered down. And I think that's the nature of legislation. Victoria being the first state to implement, I guess, in Australian context anyway, was the guinea pig. I think it's interesting, though, that we've now seen this week, the tabling in Parliament of the proposed amendments to that legislation following the review, the statutory review. And that will take, I'm thinking, up to about 18 months to be debated and actually enacted. But what we're actually seeing is, in one instance, a proposal to increase the time frame from 6 months to 12 months. And yet in ACT, which people will have access to VAD from next month, they've already gone past the 12 months to not having any time frame at all. So in the process that it takes to go through and review and debate, we're actually going to be debating a time frame which has already been superseded in the territory. So I imagine that each time we see in each of the states and territories their statutory review taking place, I think Victoria just missed out on the opportunity to look at the ACT legislation as the review period was going on. So I think it's going to be a slow process. But the government... Sorry?
I tend to think of this from a personal perspective of whether my mother would have been able to access VAD when she wanted it. So she had emphysema and chronic back pain, but she had no expected time of death. So she would not have been eligible under the Victorian legislation, but she would have been eligible under the ACT legislation that's in place now.
Yeah.
Sam, there's still gaps even in the ACT legislation. Do you want to tell us about some of the gaps that you're working to fill?
Well, yeah, this is not all good news. I completely sympathise if I was living in Victoria or anywhere around the country that 6 to 12 months is arbitrary and infuriating. Now, when they drafted our laws, sure, the 6 to 12 month eligibility criteria was removed, What we've been left with now, depending where you sit, is law and regulation that rightly so doesn't include that criteria, but there is some issues we are working on with the clinical guidelines whereby the hot button issue, dementia, they have said in the clinical guidelines, this is now a public document, that dementia diagnosis, given that from day one you are terminal, but you may still have decision-making capacity, yet you are terminal, but it won't be included.
So
now,
are you saying that you won't be able to be eligible for VAD even if you still have decision-making capacity if you've only just been diagnosed with dementia?
Yes. As I understand it now, that is the current state of play, and that is, I don't think we have enough time tonight to unpack that, but I would put to you, I believe, and everything I am forwarded is that is going to be highly contentious and may be contested too. And there appears to be certainly a disconnect between the regulations and Act itself and the clinical guidelines. And we are going to have an opportunity via the Health Minister in the first 12 months to gather some data and try and work out where we should head with this in terms of people who may have gone through all the stages of voluntary assisted dying eligibility to work out if they are eligible and then lose capacity versus some of the people that we often know in their early stages there to terminal illness have already lost capacity. And that is going to be, I hate to say it, not a problem we are going to solve tonight.
No. I recall Terry Pratchett was diagnosed with dementia and chose VAD. He had to go overseas to get it. And I think people with dementia are likely to choose VAD earlier rather than living a bit longer and choosing it later because they're afraid of losing capacity. So it's a very important issue, personal for me as well. Both my stepmom and my dad have dementia, and so of course I worry about getting it myself. I'd like to be able to appoint someone who would speak on my behalf, given a set of criteria that I'd lay out in advance and choose for me in that case. Iain, you've been working with people in Victoria who have been accessing voluntary assisted dying. Where are the gaps in Victoria? Where are people trying to access it and are unable to? Or what do you see as potential for improvement in the Victorian law?
Well, some of those gaps have been, I guess, considered in the review and will be impacted by the changes that are going to be debated before Parliament. Obviously, I think one of the main ones was the gag clause that stopped doctors and health professionals actually bringing up voluntary assisted dying with their patients. It had to be raised by the patient first. So that's a recommendation that has been accepted, and hoping that these will all get through without being challenged. That will significantly improve outcomes for people, because the general sense is that most people don't actually know about VAD, not aware of it, and aware of it as an option, and it should always be given as an option with other options that you would have a conversation with your doctor about. Another one is and it's not something that can be fixed at the moment, but as we know, there is federal Commonwealth laws in place around discussing suicide on a carriage network, such as by telephone or video conferencing and those things. And that's not something that impacts people in regional locations. I mean, in Victoria, probably the distances are less than anywhere else in Australia, but
So, yes,
yeah, correct. But it's nevertheless, a lot of people are not mobile and have disabilities and are, can't really get out easily. So not being able to have a telehealth appointment with a doctor or anyone to support them is a problematic, and that's not going to be solved in the short term. I think that certainly in the Northern Territory, work that's been done, there's been a lot of work done about working with Indigenous communities and making sure that VAD is accessible to them in a culturally sensitive way. That would certainly, obviously, anything we learn from that will obviously impact our Indigenous communities in Victoria. But I feel that there needs to be significant work done with helping the general public understand what VAD is and what it's not, educating them about how they might approach the conversation. And at some point, once the legislation is updated, doctors will be able to put it on the table with the other things around palliative care and any other treatment options that they want to talk about, and provide a forum for people to make sort of informed choices about how they might access some or all of those options on their end of life journey. So I think that the dementia one, obviously, very contentious, where I feel dementia, I believe in 2025, is now for both men and women the biggest killer in Australia. It's overtaken coronary heart disease. So the thing is, we are an aging population. We currently have not enough facilities and beds and trained staff to deal with our current cohort of people who need care. As we get older and more people get dementia, that's going to become worse. So I feel that the conversation will naturally have to move away from just the concept of voluntary assisted dying and what it is, to be more broadly about, what do we consider is reasonable about end of life generally, and the fact that we might be able to save significant amount of distress and significant amount of health dollars if we provide options for people who are of sound mind and who decide, I don't want to keep going. If we give them an opportunity to take that and leave us in a dignified and reliable way, it's going to achieve a double outcome. They will get the end of life option they want, and it will have a significant fiscal impact on the health budget, which I think we're going to have a conversation about.
We do have to be really careful here that we're taking individual choices and compassion into account over and above.
Absolutely. I don't mean to suggest that this should be done as a budget saving exercise, but I think the reality is we're resource poor in the area. So if I put my hand up and say I would like to, go now and in this way, we need to change the conversation so people actually take that seriously. Sound up.
Yeah, I don't take Iain's points lightly. In the stages of palliative care, coming back to the eligibility criteria and the suffering, I think what is most understandable, and Go Gentle Australia talks about evidence-based policy making, is in those palliative care stages, and I've got no doubt Iain has seen more of this than me, is the reality of terminal sedation, the reality of what a dementia care ward looks like. The story that came out of Victoria today was the reality of what 19 rounds of chemotherapy actually looks like. And some of that, when VAD is implemented, may be arguably easier for the community to digest, but the financial points too is something that I think people learn at the last minute in a very difficult manner. For example, having lived and grown up in Canberra, I've been through the healthcare system in Canberra. Canberra and ACT is amazingly affluent. We are very privileged. And I have seen what I know people who I've shared experiences with a lot of colleagues who've seen what the last stages of palliative care can provide, and what money actually gives you at those last stages is not what people would think. I don't think the reality is what people expect. Sorry, that was just a comment rather than, yeah.
I can speak a little bit to palliative care. I sat with my father-in-law in 2017 when he died in a palliative care unit in Townsville, and I will always be grateful that he was able to get into that facility and be cared for there. They kept him as comfortable as possible, and the environment was lovely, and there was support for the family, and it felt like the whole family was gathered around him and were able to spend some precious time with him in his last few days.
I think our best comment we can make there is that VAD, stop me if you disagree, Iain, is that VAD is complementary to good palliative care. They're not, they're not disconnected.
Not either or.
It's not either or. They will never be disconnected. For some people who still have decision-making capacity from the first day of their diagnosis, they are on palliative care. And there is not a person I know on this earth who has advocated for VAD who would say that palliative care is not important too. I am all for increasing budgeting to good palliative care in the ACT and the Northern Territory and everywhere else.
And yet that was an argument that was raised against the introduction of VAD in Victoria. But people were saying, you just want to have VAD instead of palliative care. That's a bad decision. And absolutely not. No, we need to have both. And even individuals should be able to have both, have palliative care to keep you comfortable for as long as possible, and then have the option to have VAD at the end.
I can understand how those things are connected. Why would people have an issue with that? Like, clearly you need both. Like, palliative care, as far as I'm aware, is just looking after people that are in that situation, that are dying, and caring for them. And voluntary assisted dying is making that decision to speed the process up, I guess.
It's not even, I mean, it may be about speeding the process up, but ostensibly it's about choice. It's about an individual deciding, with everything else that they have to think about and consider, that this is the way that they want their life to end at a time and a place of their choosing. And so I think they're very different concepts, and they often get talked about together, and it's what either or. But
I can't understand. That doesn't make sense to me as a layman. To me, they are both necessary and different things entirely. It wouldn't be one or the other. That doesn't make sense to me.
And I think, it would probably be fair to say that people who work in palliative care, of course, want more resources. They need, like lots of health areas, need more resources, and they could see the value of what they could be able to achieve if they had them. So it may be easy to be concerned about resources going somewhere else to this other thing, when they can see from on the ground experience what difference they could make if they had more money. So I think there needs to be a lot more money for palliative care. But I absolutely don't think that we should be saying palliative care is always going to be the right solution for every person, because even if palliative care works 100% of the time, it doesn't necessarily answer the thing, I don't actually want to go down that pathway, I want to go down this pathway, and I have a right to make that decision, and that's the difference, I think.
Sam, you had your hand up earlier.
Yeah, I put it down again. I'm actually a high school teacher. I put it down again thinking I've said too much already. Just
quickly, Sam, if I can just jump in for a second. I think you were trying to make comments and you were doing it in the private chat between us. So you need to go to comments on the top right-hand side. You should,
thanks, Brian. I was going to ask that. With respect to questions, do your members of Humanists Australia, can they put them in this here, or do I need to go to the YouTube feed to see their questions?
I'm pretty sure you can see it from where you are, because Marianne and I are managers of the channel. We can see it. I assume that you should be able to. You should be able to comment. Do you have a box that says comments?
I certainly do, yeah. And I just wanted to make sure if people had questions that I wasn't speaking to.
If you click on that one, and the things that you put in private chat, if you put them in comments instead, our viewers will see those in the chat. And I can post them. So those ones that you posted previously, it was only us, for people that would be able to see those. So if you want viewers to see,
one of them
do it in comments.
Fantastic. One of them, those comments, just for reference, was something Iain said about telehealth. I believe I read today that the AMA has gotten behind the Victorian amendments on telehealth. Is that right, Iain?
Well, I think the telehealth issue is a Commonwealth issue, because the legislation, I understand the legislation is a Commonwealth rather than states, which means that it can't be just Victoria decides that they're going to make the changes to make this easier. So I think there's a lot of people behind it, but
agreed. I don't disagree. I'll try and find the article. Pleasingly, I think Victoria has been one of the first ones to have a look seriously at the telehealth amendments, and that everyone has been. I think you'll be on the forefront of that, if I understand correct. But maybe we can talk about that tomorrow, actually. Yeah. I think you'll be on the forefront of that, and that AMA has said, yep, we agree. Queensland is a big state. West Australia clearly has to do telehealth. We're actually the anomaly. We're tiny. Canberra actually doesn't do a lot of telehealth, but I do feel for those big states who have to do more telehealth. I apologise. Iain, what was your other point? Sorry, you were just saying.
On that, I think my point was that it's been raised as an issue all along in terms of access, equitable access for people who either don't live in metropolitan areas, or because of some health issue or disability find it difficult to actually get to an appointment. And it's always been the case that it's an issue with discussing, because voluntary assisted dying is the conversations are considered to be conversations about suicide, and discussions and conversations about suicide are not legal to be held on any carriage service in Australia. So I think it's a broader issue.
That was right. And so you went on to say, with respect to palliative care versus VAD, and I think we all agree they're complementary. One of the most pleasing things I have seen in the past 2 or 3 years was part of the Go Gentle report that said there's been a steep increase, I think Australia-wide, in the data of people being able to receive palliative care at home, complementary to their VAD. I think it was as much as 30% increase, because we all know that most of us express we'd like to pass away at home, or There was a story out of New South Wales where the ambulance officers took this gentleman to the beach where he could do VAD at the beach and the police assisted. I think that's part of it to me, that I may be being a little philosophical here rather than an objective, that you can still get great palliative care at home. We sort of associate that so much with going to the hospital, going to the nursing home, whereas the data suggests now in some of the states that passing away at home is now a realistic possibility.
Palliative care in the home has been around for a long time and has worked extremely well. I think the other point that we need to make is that I think the data says that 1/3 of the Victorians who applied for VAD and got access to it didn't actually use the drugs. And we got to consider the issue whereby people just feel a level of comfort knowing that they can access the drug if they wish to. But very often when they do have access to them, it takes a lot of the anxiety and the stress away. And the palliative care, in whatever form it takes, both physical and psychological care, gives them a very peaceful and reliable end of life. So, as it does in lots of instances. And so having that, we shouldn't underestimate the value of being able to access the drugs through the VAD process, and just know that they're there in case we want to use them, and very often we won't.
Let's bring the conversation back around more to the experience of VAD for the person and their family, rather than the technical aspects of legislation. Iain, I think you have a fair amount of experience in that area, and I'm wondering how families deal with VAD. Do you see families where it is a struggle, or do you see them finding comfort?
Well, I've had, I guess, limited experience compared to the numbers of people who've been involved. But I think the first thing to say is that it's fair to say that families and significant others in someone's life have issues around the whole end of life experience, not just about VAD. It's about even the choices that people may make about treatment. You know, they want to have treatment or they don't want to have treatment. They want to be buried, they want to be cremated. There's all these things that come out at the end of life within families that people can disagree on. And it's not that common actually to be involved with families and friendship groups where everyone is on the same page. So I don't think VAD is necessarily different in that stage.
We don't really talk about death enough, do we?
Correct, because we don't talk about it at all for most of the time. So when we are faced with it, we are numb with the fact that ourselves or the people that we love are going to die, and all the things that matters. And we're so caught up in that and the sort of shock and the grief that it's then difficult to have really objective discussions about all of the things that you have to think about. And so if we don't think about those things in advance and plan for them, it makes it really difficult at that end stage. Getting back to VAD, it's quite a new concept for a lot of people. A lot of people don't know about it. So the person who is requesting it may have been doing some research and maybe all over it. It's often a conversation, like many end-of-life conversations, that when you bring up, people don't want to talk about it. They'll say, don't be morbid. You know, they try and close the conversation down. And so people are sort of uncomfortable with it. And that often relates to their own mortality and how they feel about their own sort of life and death. So the thing is that it's a challenging conversation for families to bring up, because most of the time people don't want their loved ones to die, and they don't want them to suffer, but they certainly don't want them to die sooner than they might have to in their heads. And so it can be quite challenging to bring this up and get the family support that people need and want to be able to make that decision and be comfortable with it. Because most of us don't like going out on a limb and doing something that just suits us if the people we love are not supportive. And so I've seen instances where people, it's not coercion, but people simply decide not to do something because they know it's going to hurt or upset people that they love. And so I think the way around that is more education, and certainly more ability to have conversations in that end of life space and before the end of life space, so that when it actually happens, it just becomes a natural occurrence.
Yeah. I had numerous conversations with my mother before she passed away. So she decided probably a good 6 months before she died that she wanted to pass. And she did a lot of research for herself, and she got me to buy the book Final Exit for her. And when I was in the coroner's court, that was the thing that might have landed me in jail at the time, that I had helped her by buying that book. But she was absolutely determined that she was going to do this. She would have done it with me or without me, with or without my father being present. Oh, we've lost Sam. And so, you know, it was very difficult for us, but I didn't feel I could walk away from her. I needed to be there with her, and I was ready to face the consequences.
Yeah. And one of the things that is, you know, the recommendations in Victoria that we're going to be seeing is to help us have those conversations more easily, more resources within the VAD sector so that there are more people around. Because when people start engaging with the VAD program and they progress through it, there are lots and lots of great people who make the care navigators and the pharmacists and the various people who are involved, who really support both the individual and their families. And so one of the recommendations from the Victoria review was to have more of those people, more training and more numbers on the ground, so that as the numbers hopefully increase over time, there is still access to the same amount of professional support that is currently available, because there's lots and lots of questions that come up, and if you have people available who can answer those questions, it makes the decision-making process and the journey much easier.
Iain, I'm not really clear on what the process looks like for the dying person and their family in Victoria. Are you able to describe what happens from diagnosis through to passing?
Well, currently it's, I guess it's a 3-stage process. One of the tenets of voluntary assisted dying eligibility is that it has to be enduring. So you have to be, the person who's requesting it has to request it at least 3 times in the process to demonstrate that they're continuing their continual interest in it going through. So it's not necessarily an upfront conversation with the doctor and thinking that might be something I'm interested in, and then being not sure. They have to be able to demonstrate in 3 different occasions. But they have to have a conversation initially with a doctor who assesses their sort of general health potential eligibility for VAD. And then they have to do that a second time and in writing, and it has to be witnessed. And then they have to do it a 3rd time. So there are doctors who are required to currently form a view. So it may not be about forming a view about whether the person has got a particular diagnosis or a particular illness, but it currently isn't the case in Victoria that they have to form a view about whether or not they're likely to die within 6 months or 12 months if it's a neuromuscular disease. And so that's a tricky thing. One of the challenges that people with the neuromuscular diagnosis had was that they needed an extra review, and particularly for people who don't live in metropolitan Melbourne, but not just those. It was sometimes very difficult to get a neurologist who was trained to be able to make that assessment. So they needed a third one. But what the typical person needs is the original doctor plus a doctor who is a specialist in the disease that the person is dying from. So maybe an oncologist if they're dying from cancer.
Right.
So there's obviously paperwork and various aspects that have to be provided in terms of proof. So they have to go through it. They have to be assessed as understanding that. So obviously, they have to be of sound mind. They need to be able to continue to demonstrate that they understand what they're asking for, what the consequences of it are, and that doesn't deteriorate through the process, as sometimes can be the case. But there are great people in terms of care navigators and others who make that process so much easier for people, because coming into it cold, so to speak, there would be so much you'd have to try and work out for yourself. But the care navigators assist you through that process. They help the person understand what has to happen next and how it has to happen. They put them in touch with medical professionals who are VAD trained and willing to assist. One of the other changes that will be implemented in Victoria, which will be covered off in the ACT, is that if a particular doctor has some ethical views and does not want to participate, they will now be at a minimum required to refer the person or provide them information about where they can get advice from. At the moment, they don't have to do that.
So that's potential stumbling blocks for people.
Correct. And then once all of that's in place, there is a minimum period from the first application to the final application, which I think currently in Victoria is 9 days, which is quite a short period, but it rarely can take place in that. It can sometimes take months, depending on the situation. But then once they get everything approved, then the process is fairly straightforward. The State Pharmacy Service here in Victoria, who are based at the Alfred, they come to the person's home with the drugs and they educate them on how to use them and do all that. So that all happens. And then once they have the drugs in their hands in a sort of locked box, it's entirely over then to them when or if they in fact choose to use them. Is
it something they need to inject, or it's a tablet?
So it varies in the various states and territory legislation. Victoria being the first one, was the default position was that you needed to drink the substance, and that you could only have it administered intravenously or through a parenteral tube if you were not able to swallow. In other states and territories, as it's progressed, you can have an option of whether you want to take it orally or whether you want it to be administered. There is a little glitch in that currently, if you apply to take the substance orally, you're given a sort of permit for that. And if then you can no longer swallow and you want to go to an intravenous, you have to apply for another permit for that. So that I think that's being ironed out in the proposed changes as well, so that once you get a permit, it doesn't really matter how you end up having it administered. Yeah,
that makes sense. Sam, do you know anything about what the process is going to look like here in the ACT for people? And you're muted at the moment.
Just unmute, Sam.
There we go.
Thanks, Brian. You're a gentleman. Just for anyone listening, sorry, I've got a 6-year-old and a 6-month-old in the background, so I'm struggling with a few things. So the legislation points and a few things Iain just spoke about, I was listening intently. Marianne, you asked me about process questions for ACT. I'd probably say I'm probably not the best person to ask questions about for processing ACT. Tony on our committee and Roy are all over process. And I would say the pleasing factor out of that is our nurse practitioners will be a bit more of the process, and independent witnesses. I've been in contact with Victoria about becoming an independent witness and so on. But I'd have to say, just point blank, I'm not perfectly all over the process and the procedure about what's being implemented. Suffice to say, what I know is pleasing, and I think it'll be good. I think today I saw nurse practitioner Kate Reid was on the email addresses today. I hope she's listening. Hi, Kate. Just coming back to a few things about the practitioners and the doctors assessing capacity and reviewing the decision of the person 2 to 3 times, seeing where they're at. Do you know your GP well? Do you know your expert practitioner well? I guess I just wanted to say, Iain referred to a big point about coercion and where we're heading with this. There are people in Australia who are trying to work out a way where those who may have decision-making capacity might be at risk of coercion. And ACT may be the first people to be able to unpack this issue. Having said that, just for anyone who's listening who's not up to speed, there's a study that has come out of Charles Sturt University about decision-making capacity and dementia patients, because it's going to be very difficult to work out self-administration versus practitioner administration for the doctors, and we all know it's going to be difficult for the doctors. On the other hand, sorry, I'm rambling a bit. On the other hand, there's another study coming out of Queensland where they're trying to work out a way where VAD, for a person who still has decision-making capacity, but they know they are going to lose it, could be addressed, versus the person who has already lost decision-making capacity but may want to make an advanced request model. And that's going to be complex to unpack. I'm going to apologise. Sorry, I'm a bit sleep-deprived tonight to that.
That's all right, Sam.
Yeah. The coercion point Iain made is sound, and it comes up all the time from the opponents, particularly when you talk about decision-making capacity. The thing is, everything I read is that the evidence suggests that most families, if coercion is a factor, it's that they want to keep the poor person alive. They sometimes don't recognise the fact that person needs autonomy and just wants to make decisions for themselves.
It's selfishness out of love, isn't it?
Yeah, out of love. It's very well intended. It's very well intended, but the Queenslanders looking at this, there's if everyone's not aware, there's a PhD candidate up there working under Ben White and Lindy Wilmont, who are trying to unpack if we can make laws, humane laws in Australia that work out a strategy for people who may have lost capacity already or who know from the day of their diagnosis that they will lose capacity. How can we work out a system whereby maybe the doctor administers their VAD prescription, or a VAD attorney does, or they do it before the fact that they know they've lost capacity? And that's where I'm trying to work out in the bigger picture how these things could work. And
because at the moment there's no jurisdiction in Australia that allows for VAD for people with dementia yet, right?
Yeah, and it's not just dementia too. Sorry, I should just say that there are other cognitive diseases that will affect people, and we need to look at that. And credit to the ACT politicians last year. They tried to investigate this, but they kind of kicked the can down the road. And now they are looking at, after 12 months of implementation, taking some data, and so they should, of what our new system will look like, and then trying to create a system whereby anyone who might be at risk of losing decision-making capacity through terminal illness may be able to take advantage of the voluntary assisted dying process. Iain, yeah, please.
I just wanted to say that in the ACT legislation, and I understand it will be included in the Northern Territory legislation, there is reference to the fact that although it's considered premature at the moment, that when the statutory review of the ACT legislation happens, they should consider this sort of concept of advanced access, where people would be able to put it into an advanced care. So it's been put onto the agenda, I guess, for the review 3 years down the track. So that, I guess, is starting the conversation, at least.
Well, Iain, they actually did one more thing. Some colleagues of mine that have been doing this for a lot longer than me were not pleased to wait for the statutory review, but I do understand that's a process. And what happened was there was if you're not aware, there was in the lead up to our laws being passed, there was a motion by Dr. Marissa Patterson. Did I refer to this before, about addressing the issue of capacity that we know has occurred around Australia with your system that has been implemented? There's examples where at the last moment, and case studies, someone loses capacity, and then all of a sudden they can't rightfully so have their prescription administered by themselves, a doctor or a friend. So that motion was pleasing, but we said it was a little too narrow, that if you're going to look at the matter of decision-making capacity, it needs to go further than that, because we all know that people on day one can potentially be diagnosed terminal, non-treatable, and unfortunately they might lose decision-making capacity. So I sorry, to come back to Iain's point, I just take my hat off to the practitioners, and I don't see how people will be coerced to take a VAD drug. Sorry, I just don't believe that.
Yeah, agree.
Yeah, I think on the other side, most of the time people want to keep their loved ones alive. Sorry, Mary-Ann, so please.
I could imagine situations where someone stands to inherit, for example, where they might want to do something like that. So it makes sense to have safeguards in place, absolutely. Yep. We've only got a couple of minutes left. I thought we might finish up just with, I'd like to ask Iain, if you could change one thing about the VAD laws in Victoria with the review that's coming up that would really make people's lives better, well, what would you change, and how would it improve things for people?
Well, I think that it's a bit broader than that for me. I think the Victorian legislation, like it is everywhere in the world other than in Switzerland, is a medical-based model rather than a rights-based model. So at the end of the day, I still have the choice of applying to access VAD, but I need to comply with very rigid, criteria. And at the end of the day, whether I get access to those drugs or not, it's still a medical decision. It lies with those doctors who are going to make a decision about whether I'm likely to be dying in 6 to 12 months, as it stands in Victoria at the moment. I would like it to be, and it's a bit of a way off yet, but I'd like to move to a rights model rather than a medical model, on the basis that I have a human right to end my life at a time and way of my choosing, regardless of whether I've been diagnosed with a life-limiting illness. So I think that, you know, it's fantastic that we've got VAD legislation in Australia. It's fantastic that each time states and territories enact it, that they learn from the other one, and it changes a bit, and that's the way it will work. But I think that at the end of the day, it's still a process that is only going to be only a small number of people will ever be eligible for. And I would like the change to be that it moves into a much broader right-based model, which is that I have the capacity to go, and as long as I am able to be considered of sound mind, I can access the drugs that I require to end my life at a time of my choosing. And that's the sort of nirvana that we want to go to. So anything that we can do along the way to try and move from where we are to there, I think would be a good thing.
It's kind of ironic that Northern Territory, being the first Australian jurisdiction to bring in the VAD laws, is now also going to be the last Australian jurisdiction to bring in VAD laws, and maybe that gives them the opportunity to have more progressive laws than they otherwise would have had, given the learnings from the other jurisdictions.
Well, it certainly looks like they're incorporating some of the latest learnings, particularly from the ACT, so that's a great thing.
Mm-hmm. All right, we are at time. Thank you so much for coming tonight, Iain and Sam. Thank you for being our tech person, Brian, sorting us all out. Been great to see everyone tonight, and I hope we see you again at a future Humanists Australia live stream event. Keep an eye on our YouTube channel and our meetup group for future events. Take care, everyone, and good night.
Thank you.
Use your eyes, know yourself, realize, understand and empathize. We could learn to fill the world with love.